Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing at Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we will try to get them answered during the webinar. Now, allow me to introduce Dr. Rotenberg. Dr. Sean Rotenberg received his dental degree from the Medical College of Georgia and achieved a certificate in periodontics and a Master of Science degree from the Ohio State University, where he served as chief resident. Dr. Rotenberg is an assistant professor for the Division of Periodontology at the Ohio State University College of Dentistry in Columbus, Ohio. He also maintains a private practice in the Columbus area that focuses on periodontal therapy, implant therapy, and periodontal plastic surgery. Dr. Rotenberg serves as staff periodontist for Nationwide Children's Hospital. He is a diplomate of the American Board of Periodontology and has co-authored or authored several peer-reviewed articles in the Journal of Periodontology and National Journal of Oral and Maxillofacial Implants. Dr. Rotenberg's current research interest includes soft tissue augmentation and peri-implant disease, and he has presented at both national and international professional meetings. Dr. Rotenberg, I'll turn it over to you. Thank you very much for being with us again tonight. We appreciate the time we get to spend with you. Over to you.
Thanks, Russ. I appreciate the time I get to spend with you guys too. And I appreciate everyone logging in. Happy Wednesday. It's 9 o'clock at night here in Columbus, Ohio. And you know, there's nothing more that I like to do on a Wednesday night at 9 o'clock than to do webinars. And I'm sure you guys are the same way, everyone at home watching me. If you're on the West Coast, it's earlier. Good for you. If you're on the East Coast, hopefully you're tucked into bed a little bit, getting ready to just cuddle up and watch a webinar. We've got less than an hour to talk about all this wonderful material I'm going to talk about tonight. A great new soft tissue product, some surgical techniques. So I'm going to try to keep it as interesting as possible. Lots of photos, very little words, keeping you interested. And I appreciate any comments afterwards, any questions. So yeah, let's dive right into it. Disclosures. I don't really have too many. Osteogenics, obviously, they're paying me a little bit to be here tonight to speak to you, but I'm not on the salary with them or anything like that. I do work at Nationwide Children's Hospital. I do also work at Ohio State University, but 4.5 days a week, I'm in my private practice with my partner, who's an oral maxillofacial surgeon, and our associate, who's another periodontist, treating patients every single day, and I love it. So, you know, again, I'm condensing a lot of material into this presentation tonight. Normally, I'd have a background on soft tissue augmentation, the different types of autogenous grafts that we have out there, free gingival grafts, connective tissue grafts, pros and cons of each of those. But really, I had to condense down to show you, you know, some really interesting cases and cases using this new material. So this is what I see every day in my office, right? So this is lower central incisors. Any periodontists out there listening know this is a very, very common referral to our office. Lower central incisors are prone to recession because you have a freedom pull, a naturally thin tissue biotype in the area. And you know, normally what we're doing to treat these areas, we're doing a free gingival graft or a connective tissue graft to try to not only gain root coverage, but also to gain keratinized tissue and attached tissue to improve the health of the tooth. So in a situation like this, typically my go-to is a connective tissue graft. Why do I use connective tissue grafts? Well, they're the gold standard, right? The majority of studies out there, the big systematic reviews show that a connective tissue graft is the gold standard. Why is that? Well, because not only can we gain root coverage, but we can get keratinized tissue as well, especially if we leave that connective tissue graft exposed. If you look at the Chambron systematic reviews, they all show that really when it comes to root coverage, keratinized tissue, patient morbidity, truly the connective tissue graft is the gold standard when you compare it to all the other materials out there, the other autogenous techniques as well, free gingival graft, chronally advanced flap, and then also compared to allografts and membranes. But what happens when patients come to your office and they really don't want to use their own tissue, mainly because they've heard horror stories about how you have to harvest that tissue? Well, we do have good alternatives. The main alternative that we give to patients, we give as an option, is an allograft tissue. And allografts have been around for a long, long time. Dr. Harris, back in 1998, took Alloderm, which was then being used for burn victims, and said, well, I wonder if I can use this for root coverage. And it's, these allografts, they process it so you can't reject anything. You get rid of cells, you get rid of any sort of DNA, bacteria. In the original products, there were antibiotics added to really create this collagen matrix that's devoid of any cells. And Dr. Harris found that using this for root coverage procedures actually worked. When we look at studies over time, over the past 25 years, they've all shown good success with allografts. Now, not as good as autogenous tissue. Nothing beats autogenous tissue. But even in a recent meta-analysis, this was a fantastic meta-analysis done by a lot of people when they were still at Michigan. Now some of them moved off to Harvard, but found that in a great meta-analysis, they found that both connective tissue grafts and acellular dermal matrices, which are allografts, they both increase keratinized gingiva, both increase gingival thickness, both increased got gains in root coverage. But ultimately, as we know, the connective tissue graft, the autogenous tissue graft, gave better results than an acellular dermal matrix, than an allograft. So, with allografts, there are plenty of pros to them. We have a good aesthetic outcome. There's no donor site, which is primarily the reason that we use allografts in soft tissue grafting. Because of no donor site, we can treat more teeth. We have a larger range of treatment. We can treat an entire quadrant without thinking about it, because we know we're not limited by the palate. And with that, there's a less initial patient morbidity. There's only one surgical area. There's not two. We don't have to go to the palate. And as far as the outcomes, they're very successful. Here's a case where I was treating canine to first molar. A patient had class 5 restorations placed. Obviously, I sent the patient back to their restorative dentist to have those restorations removed. Restorations were removed. I used a traditional tunnel technique to create my recipient site. Here's my allograft at the time that I used to augment the area. Inserted the allograft into the tunnel, used sling sutures to chronally advance everything. And lo and behold, we had a nice result in terms of tissue thickness, in terms of root coverage, and gains in attached tissue. Now, because we coronally advanced the tissue, we weren't able to really gain much in terms of keratinized tissue. But again, the fact that we didn't have to go to the patient's palate, the patient was very happy. And truly, this was, when the patient first presented to my office, this was their chief concern, was they didn't want to have to go to the palate, again, because they heard horror stories. So there are disadvantages to allografts too, right? I just said, allografts, we have to chronally advance everything. We have to cover allografts 100%. When we don't cover a traditional allograft all the way, we typically do see necrosis of that allograft. But because we're chronally advancing the tissue so much, we get limited gains in keratinized tissue, because you can't really get a lot of keratinized tissue if you're covering your graft with mucosa. On top of that, from an aesthetic standpoint, because we're coronally positioning the tissue, we're also coronally positioning the mucogingival junction. So sometimes if you're just treating one one sextant or one quadrant at a time, sometimes that can cause some discrepancies in the symmetry of the mucogenital junction, which can affect aesthetics. Also, allografts can have more significant post-op complications. Any of you out there that have used an allograft soft tissue and it's failed, know that sometimes these failures can be devastating, not only in terms of pain and discomfort, but infection. And truly, it's an all or none type success with allografts. Because of the allograft being devoid of any cells, a lot of times, yes, you have less initial morbidity, but it takes a little bit longer for that tissue to mature because instead of just kind of reconnecting vasculature where you would with an autogenous graft, you really have to start getting cellular infiltrate into that matrix and growing new cells, growing new vasculature, which can take a little bit longer than autogenous tissue. And again, based off other Harris studies, we know that the long-term outcomes of allografts are not as good as a connective tissue graft. Yes, do we have stability and root coverage to some degree, but really not to the extent of an autogenous graft. So when a patient comes to my office, I don't tell them one way or the other. I give them all their options. And if they truly do want an allograft, I still tell them, listen, 10 years out, it may not look as good as autogenous tissue, but especially if we're treating many teeth at the same time, I'll let them know that it is not a bad trade-off because of the fact that we're going to have less initial morbidity. So that morbidity, when it comes to allografts, typically it's in the failure rate. When we see allografts fail, they really fail completely. And this is one of my cases where I treated an entire arch with allograft. And when the patient came back 2 weeks later, you can see significant exposure of that allograft with infection, with pain. It smelled awful. The patient said, they said, I knew something was wrong because it smelled like death in my mouth. And truly, that's what it was. It was all this necrotic allograft tissue that was just sloughing away. And again, this turned me off from allografts. This was early in my career. And this really turned me off and kind of made me fearful of allografts for a long time until I started, trusting them again. But if you're someone out there who's not using allografts, I would have to bet that a large reason of that is because the fear of potential complications. Now, does that fear translate, into something that I worry about every day? No. As time goes on and your skill level goes up, complications get less and less. And again, here's another case where I treated it with an allograft, and you can see a really nice result. Good increase in tissue thickness, root coverage. And again, patient was very happy. And at the end of the day, sometimes a patient doesn't worry as much about the millimeter that you were able to gain or not. A lot of times they're really concerned about the morbidity associated with the procedure. So when I'm discussing autogenous tissue versus allograft with patients, and when I'm thinking about it in my mind, yes, I'm thinking about patient preference. If a patient comes in and they say, listen, I've been all over the city and everyone's told me that I have to use my own tissue and I refuse to, I want to use an allograft. Okay, if that's the only option you're giving me, sure, we can use it. There's some patients who want to use it because they want to treat more teeth at the same time. For orthodontic cases, when patients have a very, very thin tissue biotype, and especially in adults, and they're going to go through extensive orthodontic treatment, sometimes it's our only option unless we want to put that patient through multiple autogenous grafts. We'd also discuss the morbidity and the long-term outcome. I'll say, Mrs. Smith, yes, you're going to have less morbidity up front, but 10 years from now, it might not look the same if we use an allograft versus your own tissue. But sometimes, again, the fact that you're avoiding that morbidity up front, it really, does kind of weigh in if we're thinking about the long-term outcomes not being as good as autogenous tissue, but still being very good. And then also the risk of post-op complications. And that's really, the post-op complications, that's truly, again, where I think a lot of clinicians avoid using allografts because they're just afraid of those complications. Now, with those complications, those can be avoided, again, with technique, more skill, as far as how you insert the graft, how you cover the graft, how you design your flap. So that's something that we're going to talk about today. So when we think about the post-op complications, again, yes, this was a very bad post-op complication, but when I talk to colleagues of mine and we talk about it and I say, well, why aren't you using an allograft? They're sometimes more concerned about something like this. This isn't a true complication, but this is something that occurs when you use a traditional allograft. When you use a traditional allograft, any of it that gets exposed kind of necroses. And a lot of times in the past, I used to tell patients for post-op instructions, I'd say, listen, you might get a little bit of a smell. You might get a little bit of a taste. That's completely normal. Don't worry, that'll go away. And I used to be nonchalant about it until I did an allograft on my wife about 10 years ago. And we're sitting there on the couch and I say, oh, Katie, how you doing? You doing okay? Oh, yeah. She goes, it smells like crap, though. I said, oh, that's normal. That's normal. Don't worry, everyone. And we're sitting there watching TV. I think we were watching The Bachelor or something like that. And I wasn't really paying attention. And, she takes her finger and she rubs it on her graft and she sticks it right under my nose. It smelled like poop. It was awful. I couldn't imagine. This is what patients go through. They have to have this taste in their mouth and this smell in their mouth. And her graft did very well. It was successful. But just that small amount of necrosis, again, affected her post-op experience. So 25 years, we've known about the exposure of allografts and the potential complications and the fact that they don't heal maybe as well as autogenous tissue. Why hasn't anything been done in 25 years? 25 years ago, it's almost 26. The iMac just came out. You look at what we have these days. This is the iMac now. It's in our hands. So for 25 years we were able to take an Apple computer, put it in our hands, and we haven't been able to do anything with allograft soft tissue. Well, obviously until now. That's why we're all here today, to learn about microderm. So microderm is an allograft. It's just an allograft with patented dermal microcuts. Basically, they take an allograft and they've made these cuts and layers in it to increase the surface area. And that makes sense. And I don't know why someone didn't think about this, 10, 15 years ago. So it's not, again, it's, I get questions all the time on email, Instagram, where on the street, tell me more about this product. Is it safe to use? It's just allograft. It's just kind of making the wheel better. It's not reinventing the wheel. It's allograft that has these cuts to increase surface area. It's like when we took smooth surface implants and made them rough, right? It wasn't people like, oh, I don't know about that rough an implant. That sounds completely, no, it's an implant. They just made it rough. And because they found, okay, you increase the surface area, heals better. Well, guess what? That's the thought process with microderm, with microsurfaced allograft. This is what it looks like under scanning electron microscopy. And you can see the layers there, the increased surface area, the deep microcut. And again, what this allows for is greater cell infiltrate, blood flow to the area, which I'm going to show you how absorbent this material can be. So question I get sometimes too, are there any studies to show that we see improved healing? Because yes, in theory, increased surface area makes sense, but does it really make a difference? So if we go to the medical literature, recently, last year, Marinelli, the study by Marinelli, they looked at burn victims. Again, we're going to the medical literature. They looked at 20 patients with equal burns. 10 of those patients got traditional smooth surface allografts, and 10 patients got microsurfaced allografts, just like microderm. And they looked at these grafts histologically between 12 and 19 days with some biopsies. So again, when we compare traditional acellular dermal matrix and microsurfaced acellular dermal matrix on the left, you can see traditional acellular dermal matrix is more compressed, not as much space to allow for cellular infiltrate, and again, doesn't have any sort of microcuts, again, to allow for an increased surface area. So how does that translate into results? Well, in their results from the biopsies they took at different healing points, they found that the microsurface grafts had greater cell concentration in them between 12 and 19 days. They also showed greater thickness of the graft material, which related to the fact that these didn't shrink as much as time went on. On top of that, they found more incorporation of the microsurface grafts into the native tissue. One of the most interesting things that I read, though, that really I thought was kind of the most astonishing, was the fact that there were more neutrophils as the predominant cell type into the cell infiltrate. And what that tells me, because when you look at natural healing, neutrophils are the first cell to get into a naturally healing wound. In the smooth surface traditional allografts, they really saw no neutrophils at all. But in the microsurface grafts, they found that neutrophils really were the predominant cell. So to me, it seemed like it mimicked natural healing more. So with microderm, because of this increased surface area, you have greater cell infiltration, which can lead to better vascularization, more incorporation, and ultimately improved healing. When you take the microderm and you saturate it with any sort of liquid, you see how absorbent it is. If anyone's ever taken a dry allograft and placed it into saline, you know that it takes a while for that allograft to suck up whatever liquid it's in, which is a lot of times why allografts come hydrated these days. But microderm, as soon as it touches any sort of liquid, immediately it absorbs that liquid. So now that we have this newer allograft, how can we put this together with our traditional flap techniques that we use in soft tissue augmentation? And as periodontists, we have all these different techniques, all these different recipes that we can pull from. And really, for me, it's truly like cooking. We have all these techniques and we have all these graft options. And really, it's not, people ask me, well, what technique do you use? I pull from all sorts of different techniques, and we should all be pulling from different techniques. A Michelin star chef doesn't follow a cookbook. A Michelin star chef has learned different recipes from different master chefs, but every Michelin star chef finds their own recipe. And that's what we all need to do as well. So we have different techniques we can use. We have different graft materials we can use now, and we can put it all together. Now, the most exciting techniques that we're using these days are really the vestibular access tunnel techniques. Now, these techniques are well documented, all the way back 2012, 2011. There's the pinhole technique, there's the Vista technique. And again, these authors, again, recipes for how they treat recession. But, the vestibular access has been around for a lot longer. This is a case I did in my residency, which was 2008, 2009, where here I was grafting around an implant that had thinning tissue, not a lot of keratinized tissue, was starting to show some of the abutment. So here I didn't want to touch the papilla. So what did I do? I used a vestibular access and pulled a connective tissue graft onto the buccal of that implant. And lo and behold, it healed, did well. We got root coverage, or we got implant coverage, and we got a gain in tissue thickness and attached tissue. So again, people have been doing vestibular accesses for a long time, but now we have certain protocols on how to do it. So the benefits of vestibular access techniques. Well, you don't have to elevate the papilla, which really reduces the risk of papilla loss. And with that, because we're not going through the papilla, because we're not going through the gingival margin, it really allows us to be able to place a very large piece of graft material into our tunnel. Before, when I would tunnel simply through the sulcus, trying to insert your graft be it an allograft or autogenous graft, was really cumbersome, and you were always fearful of tearing the gingival margin by shoving your graft material into the gingival margin to introduce it into your recipient site. With a vestibular access, you don't have to worry about that. You can just make your vestibular incision larger to insert your graft material. On top of that, vestibular accesses are nice to be able to manipulate your graft material. Sometimes you really don't have a lot of great access through the sulcus. So through the vestibular access incision, you can help manipulate your graft material to place it precisely where you'd like it to go. Lastly, the time that you spend creating the recipient site using a vestibular access is shortened significantly compared to doing it all through the sulcus. I can prepare an entire quadrant for a soft tissue graft through a vestibular access in about 5 minutes or less. If I was doing this the traditional tunnel technique going through the sulcus, it could take me 15, 20 minutes because I'm being very careful not to damage papilla, not to damage the gingival margin. But through the vestibular access, I can create an entire quadrant tunnel, again, 5 minutes or less. So why does that matter? This is one of the most overlooked studies that we have when it comes to soft tissue augmentation in the periodontal literature. This is one of I don't know why there are not more studies like this, but this was one of the only studies that looked at the time that it took to do your graft and how it affected the healing process. And in the Griffin study, they found that for every minute that went by in your procedure, you saw a 4% increase in moderate to severe pain in your patients and a 3% increase in swelling. So what does that tell me? That tells me that longer procedures, we all know this, equal increased complications. I teach at Ohio State. When a resident comes to me and says, "Why did my graft fail? Doesn't it look perfect? Look at all these photos. These photos are all perfect." I said, "It's because it took you 3 hours. You do anything for 3 hours, it's not going to go well." We all know the longer a procedure goes, the more complications that we have. So let's pull this all together, okay? So now we have a novel product that's potentially going to heal better. We have vestibular access techniques. Let's put it all together. So here we're treating the canine in the first premolar. So there's my vestibular access incision. You can see apical of the lateral incisor. Through that, I'm very easily able to create my recipient site without damaging my papilla, with causing minimal trauma to the gingival margin. Here's my microderm. Microderm is very easily cut dry. So I'm measuring it, cutting it dry, and it's very easy to insert. Actually, in this case, I inserted it right through the sulcus, and you can see, look how absorbent it is. Look how red it is. The first thing it sucked up was blood. I haven't tried this with any growth factors or PRP, PRF, but I'm assuming that might help. I'm not sure. But in this situation, you can see how blood is just soaked up into the microderm, sutured with just 2 sling sutures. And this is where microderm shines. This is the 2-week post-op, okay? When people ask me, why do you use microderm now rather than other allografts? My answer is 2 weeks. This is why. The patient comes back at 2 weeks, almost no pain, minimal swelling, and the tissue looks amazing. And this is what I have found over and over again. And it's not that, again, other allografts don't work, but on the left, these are traditional allografts that I've used in the past, and these are 2-week post-ops from those procedures. And again, do they look great? No, they're healing well, and this is where a patient will come back and I'd say, "You're healing just great, Mrs. Smith. I'll see you in another 6 weeks, and look, everything will be good." And lo and behold, yes, they would heal well. But when the patients came back at 2 weeks, again, Sometimes they complained of a smell. They complained of a little bit of swelling. But now with Microderm, they're coming back at 2 weeks a lot happier. And for me, happy patients reflects well on me. So here we are. Here's 2 weeks. Patient comes back at 6 weeks. This is 9 weeks. 4 months. You can see stability in the root coverage. And here, this is 10 months now. So you can see, and I've only been using Microderm for about a year now, but up to 10 months, we're seeing stable tissue. Again, we see stable gains in root coverage, and really a very nice aesthetic result. But the most important thing was the patient was very, very pleased. Not only were they very pleased, they had a connective tissue graft done somewhere else on the other side, not through the greatest technique. Now, did that connective tissue graft heal well? Did it succeed? It did, but success is kind of graded in different ways. And from an aesthetic result, the patient was not very happy at all. So they were thrilled with the allograft that I was able to do for them. So in my hands over the last 12 months, I've done about, over 30 cases, a lot of teeth. I typically do full quadrants. At first, when I first had Microderm, I wanted to see results before I used it more. So really within the last 6 months, that's where I've been ramping up my cases. And my typical follow-up, I see patients at 14 days, 28 days. So I see them at 2 weeks, 4 weeks, 8 weeks, and then up to 12 months. So far, I have not seen a failure. I have not seen any necrotic tissue. I have not seen infection. And right now, it is my current allograft of choice when patients do opt for an allograft. So again, no necrosis, no smell, no infection. And again, for my patients that I've seen less pain, less swelling, and overall faster healing. So more cases, again, lower premolars. I'm using a vestibular access technique, again, to create the tunnel, sutured with sling sutures. My Microderm's inserted already. And you can see this is 2 weeks. So again, to me, when a patient comes back looking like this at 2 weeks, it was astonishing. The tissue looks like it would maybe at 4 weeks, at 6 weeks, at 8 weeks. This is 2 weeks. Again, now 6 weeks. Here we are at 9 weeks. Here we're at 4 months. And now, am I getting a little bit of dieback of my gingival margin? I am, but I also don't do any odontoplasty. And this patient did have some pretty decent abrasion of fraction lesions. But here we are, 10 months out again, and you can see very stable. Patient was extremely happy, a nice aesthetic result. And again, patient's happy means I'm happy. Here's an aesthetic case. So this is a patient that was told throughout the city that she had to use autogenous tissue. She came to me. She says, I refuse. I do not want autogenous tissue. I hate how my teeth look. Everyone tells me no, but I don't want to do it. Please help me. So I said, okay, we're going to use allograft tissue. Yes, is autogenous tissue the best in this case? It is, but she wanted to use an allograft. So we did. Here I used a vestibular access incision, hiding that incision in the frenum. That's where I like to hide my vestibular access incisions in aesthetic areas. I'm using a microsurgical periosteal elevator to create my vestibular access and my tunnel, starting to coronally advance. Here's my Microderm, cutting it dry again, cutting it into 2 pieces. That's a 2x4. One piece is going to cover the left central to canine, and then the other is going to cover the right central to canine. Here I have it on straight cotton pliers, long straight cotton pliers that I use to insert the Microderm, inserting it all the way to the most distal location. There it is, very passively inserting it. You have to make sure that you just like you're doing ridge augmentation, you have passive release of your flap. There's my Microderm inserted. I'm using a periodontal probe to make final touch-ups of the final adaptation, my sutures, sling sutures, and then I close up the vestibular access incision. Patient goes off, and again, normally I would tell a patient, listen, you're going to be really swollen after this procedure. Patient came back in 2 weeks looking like this. Patient was thrilled. I was thrilled. Again, this is a 2-week post-op. Excellent result. Patient had minimal swelling, minimal bruising, minimal pain. Here we are at 4 weeks, and here we are at 8 weeks. From a cosmetic standpoint, I coronally advanced everything. So you can see how that mucogingival junction was coronally advanced. But the patient really understood that. I explained that from the beginning. And she was thrilled with the result. And she got what she wanted. She didn't want to use her own tissue. Another case, pre-ortho case. Again, vestibular access incision, hiding it in the frenum, using microderm. This was actually almost a full arch case. Here we are 2 weeks. Again, this is 2 weeks. Normally I would say this could, maybe 6 weeks, but this is 2 weeks. Look at the soft tissue response to the microderm. Here we are at 4 weeks. So again, more cases. Remove a composite, vestibular access incision, create my tunnel. And again, these are quick procedures. A full quadrant's about 30 minutes of work, not very long. Again, here's 2 weeks. For that to come back in 2 weeks, to me, is incredible. I was not getting results like that from other materials that I was using. So here's 2 weeks, here's 4 weeks, and here's 8 weeks. And again, can you see some of those abrasion and fraction lesions? You could. I told the patient they're probably going to need some class 5s to kind of fill those in completely because those are enamel defects. But again, patient was thrilled. Didn't have to use their own tissue, which they wanted. They didn't want to use their own tissue. And minimal pain, minimal swelling, and a nice result. So what happens when things get exposed? So that's a question that's been asked of me too. So here's a case where I actually had an exposure of microderm. So did the case just like it normally did, do vestibular access incision, sling sutures. Patient came back at 2 weeks looking like this. Again, everything looked pretty good, but then I said, uh-oh, what's that? So I actually had breakdown of my flap, and you can see the microderm underneath that breakdown. Now, normally with any other allograft, this would have freaked me out. I would have said, okay, listen, I'm going to put you on another week of antibiotics, and I'm going to give you this Paradex rinse. I want you to dip a Q-tip every night. I want you to dab the Q-tip on there, and it might smell. But this was microderm. I'd had lots of good success with it otherwise. I wanted to see, let's see what just happens if you do nothing. So I said, okay, you're healing great. I'm going to see you in another 2 weeks. So the patient came back at 4 weeks, and lo and behold, yes, we can still see a little bit of that microderm, but it's granulating in. It's not causing any more problems. It's not getting infected. So here's 4 weeks, and here's 8 weeks, complete resolution. Now, is there still a little bit of recession on the first premolar? There is. Is that probably to do with the fact that I had that exposure? Yes, probably. But is that still a pretty decent result when you compare the pre-op to the post-op? Yeah, pretty decent. So I was happy with it. Again, this is not autogenous tissue. This is allograft. And to me, this result with an allograft is a huge success. So is it just me? Do I have magic hands that can do this and that no one else can do this? Because there's times where I look at presentations and I go, I can't do that. This is a first-year resident, a very good first-year resident at Ohio State, Dr. Sadia Taslim. This is her case. So she's going to do everything. She said, I want to do everything. Dr. Rotenberg said, okay, go for it. So here she is making her vestibular access incision, creating her tunnel. She took great pictures. I used her pictures because she took such phenomenal pictures. Here she is inserting the microderm. There it is inserted, sutured. And again, here she is at 2 weeks. Pretty good result. Here she is at 4 weeks. So again, if a first-year resident can do it, it's a skilled first-year resident, it's again, not just my hands. So what about long-term? Do you have anything longer than 10 months? Well, I got 12 months, actually 13 months at this point. This is my wife. My wife had recession on tooth number 5, and she didn't want that smelly stuff again. So I used microderm on her. So here's tooth number 5. She's got a pretty decent abfraction lesion that's all stained. So here I am inserting the microderm through a small pouch, sutured. Here we are, 2 weeks. No pain. She didn't take Advil. She didn't have to do anything. She compared it to the other side. She said this was much better than the other side. So here's 2 weeks. Here's, I think on her, I think this is 4 months. And here's a year. So here we are, a year out. Again, good stability in the root coverage. She still has, you can still see part of that abfraction lesion in the enamel. But again, nice, decent result. And it's my wife. She was super happy because she wasn't in pain. And she doesn't have to complain to me and remind me about when I put graft tissue in her mouth and it smelled like poop for 2 weeks. So I was happy too. Here we are. This is about 13 months out, this case. So this was actually one of my first cases that I did. I said, I'm going to try it. I'm going to do a little pouch on this molar. I'm treating other areas. I'm going to do a little pouch on this molar. And this is the first case where I said, wow, I really like how how everything comes back at 2 weeks. So here I did a small pouch on tooth number 3, placed the microderm. And this is what it looked like at 2 weeks. So again, to me, I was thrilled with this result. The tissue wasn't inflamed. There was no sign of graft exposure, no necrosis. And now long-term, this is over a year. You can see, look at the mesial buccal root. Okay, did we gain keratinized tissue? Maybe, maybe. But we definitely got increases in tissue thickness. You can see that right there, and good stability in root coverage. So how do we do this procedure? This video is on YouTube if you want to watch it. I've placed it here too. So here's kind of a step-by-step of a case that I'm doing of 19 through 21, first molar to first premolar. And here you can see, here I've made my vestibular access incision. Obviously, I have radiographs, and I know where the mental foramen is. I'm not going to go with this blindly. But here I am. You can see how quickly I'm able to start coronally advancing the flap, almost immediately. And I'm using, for all my procedures, I use one periosteal elevator, a P. Charles periosteal elevator to do almost everything. And you can see how much I could really get up into the papilla. Here's the microderm taking out of the packaging, and it kind of is it's like a thicker membrane, kind of has that consistency. I'm measuring it out. Maybe I should have used a perio probe, but I kind of eyeballed it here. Trimming it dry. Once you get it wet, while it's still easy to suture and insert, it's a little bit harder to trim. So I always trim the microderm dry. And what I'll show you as well is I'm going to use some saline here to just kind of start hydrating it a little bit. And you can see how quickly the drops of saline get absorbed by the microderm. So whatever liquid it touches first is going to get absorbed, which is why I don't like to wet it first. I don't want saline to be absorbed. I want blood to be absorbed first onto that implant. Onto that graft. It's almost like when you place an implant, the first thing you want to touch that implant is blood. So here you can see my microderm insertion. Now, I was once asked the question, why didn't you insert it through the vestibule? To do that in this situation, I would have had to elongate my vestibular incision, and the vestibular depth wasn't long enough. I didn't feel comfortable making a longer vestibular incision to insert the graft through it. So here I'm doing some final positioning with a periodontal probe and using glycolon here to suture. I use glycolon for soft tissue procedures because it resorbs, it's a monofilament, so it wicks up less plaque. Tissue likes it a little bit better too in my hands compared to multi-filament type sutures, but use whatever you want. And here's everything sutured, nice coronal advancement. And here's what it looks like in about 4 weeks. So again, increase in tissue thickness, good root coverage. Patient was very happy because minimal swelling and minimal discomfort afterwards. One question I've been getting is, how do you do your sling sutures? Well, I just wanted to add it because I'm getting that a lot. I sling my flap and my graft together. So here, this is a pig jaw. We were cooking up some ribs, so I took the jaw and decided to do a little demonstration with it. So when I do my sling sutures, I look at the papilla like two triangles, and I always place my sutures at the base of each triangle about 3 millimeters from the gingival margin. So here's my suture penetrating through the flap, through the graft, and right through to the lingual. And again, here is my little triangle you can see. So at the base of the triangle. I then come around. So if I went through the mesial, I come to the distal and I go under the contact point. So there I am coming under the contact point. Then I go back again through the flap, through the graft. I always suture my flap and my graft together. And I'm big on that because I believe that the flap is the primary blood supply to the graft. And if anything's going to move, I don't want my graft to move independently from my flap. So here we are again, going back through, out to the lingual. There it is through the triangle. Back around, under the contact point, and then I tie. Other questions I've received. Have you tried this around an implant? So here is a case where I used microderm around an implant. So that's not an implant. That's just a failing lateral incisor. This patient came in, was forced by his dentist to come see me because he didn't believe that he had a problem, and didn't really have any aesthetic concerns. But we told him, listen, your tooth has to come out. It's dangling there. So you can see a significant hard and soft tissue defect. If you look at the canine, if you look at number 11, this patient would greatly benefit from orthodontic treatment to get the most ideal aesthetic result. Obviously, the patient declined because he wasn't very concerned about aesthetics, but he did want something to replace the tooth. So here's what the cone beam looks like. Obviously a very, very significant hard and soft tissue defect. So any of you that have seen my talks on minimally invasive socket reconstruction know I'm not going to do any sort of flap here. I'm going to take this tooth out atraumatically and use a DPTFE membrane to rebuild my bone. But in this situation, I didn't want to touch the papilla. I didn't want to do any sort of flap. And I was really, really worried about tearing the gingival margin. So I created space for my membrane through a vestibular access incision. So there it is. I've now tucked, you can see the vestibular access incision apical to the central incisor. I've now tucked my PTFE membrane into the defect to surround the entire aspect of that defect. Grafted, sutured, and I let the patient go off for a few months. And this is what we were left with. And you can see there is a soft tissue defect still present, and you can see we still have a horizontal defect in the ridge when we look at the occlusal shot. But as I've said before, we had a very, very predictable amount of bone that was regenerated so that I'm able to place an implant. But again, if I place the implant without doing anything to the soft tissue, the patient's going to stay with some sort of concavity there on the buccal. So what do? I flap the area, we place the implant, and now what I'm going to do is I'm going to use Microderm to bulk the buccal, to get rid of that concavity on the buccal. So I've trimmed my Microderm, I've created space for it under my flap on the buccal of the implant, and you can see, again, how quickly blood saturates the Microderm. So there's my Microderm on the buccal of the implant. I suture. And again, 2 weeks. So 2 weeks, the soft tissue looks great, very little inflammation, no signs of necrosis. A patient came back and said they had a nice result. And then you could see on the buccal from the occlusal shot how much dimension we were able to gain. Here we are about 3 months out, ready for restoration. Again, I would have loved this patient to get orthodontic treatment. I think it would really have helped with papilla, things like that, but the patient just wanted a tooth. But what I was most happy with, again, from the occlusal view, how much I was able to augment with Microderm and keep it stable, and this is 3 months out. So does Microderm work around implants? Yes, it does. So start to finish, patient's just happy he's going to get a tooth. Hopefully he takes care of his implant. So tips and tricks with Microderm if you're going to use it: trim it dry, don't trim it wet. It's much easier to handle when it's dry. There is no side specificity. There's no basement membrane side. You can use whatever side you want with the material. I definitely recommend a tunnel approach. I've seen other people do traditional coronally advanced flaps, but again, I think the tunnel approach has given me the best results. You want to insert it dry or slightly wet. You don't want to leave this in saline, definitely not for more than a minute. And then just like any other allograft, leave minimal graft exposed. However, I have yet to see necrotic graft tissue when using Microderm, if anything is left exposed. So in summary, Microderm has become another alternative to a connective tissue graft or autogenous tissue that I can offer my patients. It definitely has more surface area than traditional smooth surface allograft, which I found has shown me, has led to faster healing and less morbidity for my patients. And I'm looking forward to more studies coming out to back the experiences that I've seen. So thank you for joining me on a Wednesday night.
Thank you, Dr. Rodenberg. Really great information, great presentation, as always. It's now time for some question and answer. You really kind of answered several of the questions that we had coming in right there at the end with your recap, but I still have a few, and we have a little bit of time left. So first one here, do you use split thickness or full thickness flaps, or I guess you call it flap on your tunnels?
Yeah, I get this question a lot. Full thickness. Much easier to prepare a full thickness flap. I'm not worried about creating separate planes. And again, I believe that the majority of the blood supply in these situations comes from the overlying flap and not the bone of the periosteum. So I don't mind. Even with my autogenous grafts, I do full thickness.
All right. How far do you over advance the tissue to account for or prevent any dieback during the healing period?
So I typically only go at most 1 or 2 millimeters coronal to the existing CEJ The best studies show us that as long as you're going 0.5 millimeter coronal to the CEJ for any sort of coronally advanced procedure, that's all you really need. That's how you get the best results. So, but typically I'll go at, I won't overly coronally advance. A lot of that also has to do with the fact that I don't sever my papilla. I'm doing this all through a tunnel. So you're always limited by your papilla height on how much you could coronally advance. But I typically at most go 1 to 2 millimeters coronal to the CEJ.
Okay. What is your post-op protocol that the patient's leaving with from your office?
Post-op protocol is a week of antibiotics. Pick your antibiotic of choice. They go home with Paradex for a week, twice a day. No brushing the area for the first week. After a week, they can start brushing the tops of the teeth, but no brushing at the soft tissue for 4 weeks. Softer foods for the first week for sure, and then after the first week, as long as they're eating on the opposite side, they can eat pretty much what they want as long as they can mush it with a fork. But not back to a regular diet until about 4 weeks.
Okay. You showed basically the preparation of the graft with some saline drops. You also made it clear that you don't want to hydrate this graft for longer than a minute. Question came in: is any advantage or any issue with pre-wetting the graft with the patient's blood instead of saline?
I think look, if you're going to pre-wet something, let it be with their blood. But no, I don't see any issue with that. But again, the more I find that it's just very easy to insert the material when it's dry. Once it gets wet, you can still insert it, but especially if you're inserting it over a long tunnel, once it loses its rigidity, then you may have to rely on tension sutures to pull it through.
Okay, this might have time for one, maybe two more, but have you tried to use this product, the Cytoplast Microderm, in a Vista technique?
Well, like some of those anterior cases I showed were kind of like a modified Vista. I haven't used it, with the true Vista technique where we use composite and basically attach composite to the sutures to get the coronal advancement. But anywhere you would normally use an allograft, I would say use microderm as well. It's you're just going to get, I think, again, just faster, better healing. But I haven't used it in a true Vista technique using the composite, but I see no reason why you couldn't.
Okay, great. Last question, and then we will wrap it up. You mentioned this, but just to reiterate, we got several questions. What suture do you prefer to use in these cases, and what instrument do you use when you're working and creating the tunnel?
So I'm very simplistic. I use one instrument for everything. It's a P. Charles periosteal elevator, very, very thin periosteal elevator that has a curve at the end. There's a lot of great tunneling instruments out there, especially for vestibular access techniques. I think it's whatever works well in your hands. Suture wise, I do like using a monofilament suture, but I also don't like removing sutures, so I like using a resorbable monofilament suture. And chromic gut resorbs a little bit too quickly, so that's why typically I'll use Glycolon for these, and not just because I'm on the osteogenics webinar, but I really like Glycolon for these procedures.
Awesome. Well, thank you again, Dr. Rotenberg, and thank everybody in the audience for watching. We hope you enjoyed the webinar. Remember that that a feedback survey will be sent out to you shortly, and once you complete that survey, you will receive your CE certificate. Thanks again for your time, This has been an extremely informative hour that we've got to spend with Dr. Rotenberg, and we look forward to seeing everybody on future webinars. And once again, thanks to everybody that watched. Bye-bye.
Thanks, Russ.